Hi, I am Martha Elwenspoek. I am a research associate at NIHR, ARC West, and the Department of Population Health Sciences of the University of Bristol. In this presentation, I will show you the results of a service evaluation, and we have looked at the impact of a new integrated respiratory service on COPD hospital admissions using an interrupted time series analysis. In 2016, a clinical commissioning group, or CCG, in the UK commissioned a new integrated respiratory service, and a respiratory department of a secondary care hospital trust and a not-for-profit community provider were asked to design and deliver this new COPD service. The rationale was that more care could be undertaken in the community to free up hospital capacity and to improve patient outcomes and experiences. We have evaluated this new service by using both quantitative and qualitative methods, but in this presentation I will focus on the quantitative analysis. The new service consists of 3 different components that were implemented over the course of 2016, which I will explain in more detail later. So first I will give you some more background on COPD. COPD, or chronic obstructive pulmonary disease, is a chronic lung disease which is usually caused by smoking. Many patients suffer from frequent exacerbations of the disease, that is an acute worsening of symptoms, and exacerbations are often caused by lung infection that requires immediate attention and immediate treatment. COPD accounts for about 10% of emergency hospital admissions in the UK, and it's the second most common reason for unplanned hospital admissions. Outcomes are poor, and there is a high readmission rate. So COPD admissions represent a high burden for respiratory services, and this new service was aimed at reducing COPD hospital admissions through service redesign to benefit patients and potentially also reduce excessive COPD-associated healthcare costs. Before the development of the new integrated services and before working together with the community provider, the respiratory department already had the following services in place. One was the Hospital Outpatient Treatment Clinic, or HOT Clinic. This was for patients in respiratory distress, and patients could be referred to the HOT Clinic from primary care or by community hospital staff or ambulance services. And the HOT Clinic would assess and treat patients and decide whether the patients needed to be admitted to hospital or whether they could be discharged home. Another service was a 7-day early supportive discharge, and this team would assess COPD in patients and deliver treatment at home to reduce the time patients spend in hospital. And these 2 services had been in place for over 10 years. The Trust also had an established pulmonary rehab course that had been running for 20 years. This was a 6-week program, including physiotherapy and exercise to improve lung function. So as mentioned before, the new integrated respiratory service was commissioned in 2016, and it entailed 3 service pathways that were delivered in collaboration with the community provider. The home oxygen service was the first one to be implemented. The community provider launched a comprehensive review of oxygen provision to patients in the community, and the aim was to safely tailor oxygen prescription to individual needs and withdraw oxygen when it was no longer clinically indicated. The second one was additional pulmonary rehab capacity. This was launched in October 2016. And this was in addition to the 6-week pulmonary rehab course run by the Trust. So the community provider started to deliver a very similar course from a sports center in the community, and patients could choose which location was most convenient to them. And finally, in November 2016, the admission avoidance pathway was implemented to improve community care to COPD patients to reduce the need for treatment in hospital. The admission avoidance team would visit patients at home or contact them by phone to provide treatment, advice and support during COPD exacerbations. The community team had direct contact with the HOT Clinic in the hospital trust for advice, and as the name suggests, the aim of this pathway was to reduce unnecessary COPD admissions and readmissions to hospital. We have focused on the effects of the admission avoidance pathway and its effects on admissions. So how did we do this? First of all, we requested routinely collected hospital data from NHS Digital. So this was hospital episode statistics of admitted patient care. We used data from 2 years before the implementation of the intervention as a pre-intervention period and of 1 year after implementation as the post-intervention period. As control region, we included 10 CCGs that were demographically most similar to the intervention CCG, according to NHS Right Care, and this was based on 12 weighted variables, including overall deprivation, health deprivation, population total and population density, age and ethnicity. And these 10 control CCGs were treated as one control region. HES data consists of all episodes of care per consulted team provided to patients admitted to NHS hospitals in England. Diagnoses are recorded per episode of care instead of per hospital admission, so we limited our dataset to episodes where COPD was the primary diagnosis, to episodes that were the first episode of care within one admission, and we only included admissions that were unplanned. We then performed an interrupted time series analysis, and our expectation was that an effective admission avoidance pathway would cause a drop in admissions because of increased support for patients in the community. So the number of hospital admissions was our primary outcome. But we also expected that the intervention could lead to a reduction in readmissions and possibly a reduction in length of hospital stay. So these were our two secondary outcomes. This first graph shows the results of the primary outcome, so hospital admissions. And on the y-axis, you can see the number of admissions per 10,000 COPD patients. And the red line shows the rate of admissions in the intervention region. And the blue line shows the rate of admissions in the control region. And the dotted lines show when the 3 interventions were implemented. So first you had the home oxygen, then the pulmonary rehab, and finally the admission avoidance, which is the one we're interested in here. And we can see that the admissions follow a very similar pattern in both regions. And if anything, if you look at the post-intervention period, the number of admissions seem higher in the intervention region after the intervention than in the control. So we used interrupted time series analysis to estimate the effect of the intervention on admissions relative to the pre-intervention period and accounting for the changes observed in the control region around the same time of the intervention. This next graph shows the same data points, but also the fitted models. COPD admissions are usually higher in winter, so we added a dummy variable for winter months to allow for the seasonal variation. And indeed, we found that admissions are significantly higher in winter, both in the intervention and control regions. However, there was no significant change in level or trend in the intervention region after implementation of the admission avoidance pathway. The next graph shows a secondary outcome, which was the 30-day readmissions, the number of 30-day readmissions. And in both regions, about 10% of COPD-related admissions were 30-day readmissions. Or in other words, 1 in 10 patients admitted in 1 month were readmitted within the next 30 days. This rate did not significantly change over time, and it did not differ between the two regions. And finally, this graph shows the length of hospital stay. At the start of the study period, the mean length of stay was 3 days shorter in the intervention region compared to the control region. However, this difference seems to disappear over the following years, and in the post-intervention period, the length of hospital stay is more or less the same. So in summary, we found little evidence that the admission avoidance pathway influenced the rate of unplanned hospital admissions, 30-day readmissions, or length of stay. And as mentioned at the beginning of this talk, this study was part of a wider evaluation of the new CPD service. A qualitative study was also undertaken to explore the integration process from the perspectives of staff and commissioners involved in the new service. And to protect the anonymity of the participants in this qualitative study, I used generic names for the organization in this presentation. The findings of the qualitative analysis may help us understand the results of this quantitative study. I will not go in detail, but in summary, the qualitative data showed that although there was support for the idea of integration, staff did not feel that the organizations or the service was integrated. Communication between the organizations was poor, which was aggravated by IT problems, and there was also a lack of trust between staff from each care provider. It's also possible that a longer follow-up will be needed to see beneficial effects of the new services in the hospital data that we used. So further investigation is needed to understand the reasons why we found little evidence of an effect. I would like to thank the team involved in this research and thank you for listening. If you have any questions or comments on this presentation, please add them as a comment below the video and we will read and respond.